welcome to the AO Trauma Fireside series. We're talking about ring fixators again. And I have to say, we have the best of the best of the best for ring fixators and for this fireside. There have been a lot of good firesides. I know you guys have potentially watched some of them, but I think this one will be the best. So thank you very much, Dr. Rosbrook and Dr. Quinnen, both professors at their own institutions, are very expert in trauma, post-traumatic reconstruction, infection, bone defects, and it should be an amazing couple minutes tonight. Feel free to use the Q&A and ask questions as we go, and I'll just get through some of these slides. These are the disclosures for all three of us, and those have been all reconciled prior to tonight's talk. AO North America is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. We do not endorse nor promote the use of any product or service of commercial entities. Any equipment you see in tonight's session is for demonstration and teaching only. So the AO Fireside series has been amazing, came out of COVID, but it's been a really amazing session. We've had it is our third year and it's been quite popular. So thank you guys for your interest, and I appreciate all the faculty that have been involved over the past 3 years. So for this session, you should be able to describe some indications for ring fixation in the tibia. We're going to talk practical applications, indications for specific topics, and reasons why you really should think about a ring fixator in 2024 as a nice tool adjunct to your armamentarium. So I'm going to try to finish up in 2 minutes. Dr. Rosbrook's going to present his patients and some cases, Dr. Quinnen, and then we're going to go over some articles and references that I think will be really nice to look at. We had an infection one prior to that. We're now at May 21st, ring fixators. And then in July, we're doing one on why didn't I get this reduced right, which is a challenge for all of us. There's also the Trauma Fellows webinars, so just keep an eye out for that. All right, so here's a first case just to get things going. This is a 53-year-old male. It's in type 3A, small medial opening, lots of swelling, spanning frame. What are you thinking, Steve, about implants? There's the, there's the lesion around the joint.
Sure.
Very simple. What do you think about, Steve?
Well, I guess my first instinct is to, look at the bone and think of implants. But before I get too far into it, I'm always going to think soft tissue.
Oh my God, you spoiled it. Okay, so I'll just cut to the chase. So, Rob, 3.5 weeks, 3.5 weeks, persistent blisters, massive swelling, and I mean, a ring fixator for this one is reasonable for you?
I love it.
And
I love
why?
it.
Why?
It looks like the joint can be easily pretty well reduced with a percutaneous technique. There maybe is a small little split, or maybe not even. And that's kind of outside the zone of the injury. The real zone of injury is the metadiaphyseal area that has all that comminution. And to go in and start to put implants in and open exposures, I think creates a risk. So I think you can either approach this with a minimal incision plating technique, or you can approach it with a fixator. But those are going to be the most kind to the soft tissues. And I really like the idea of a fixator for this. It's very safe.
Yeah, I agree, right? I mean, I think we all agree, and I think from tonight's session, I think for those of you who don't use ring fixators or think about it, I think you'll see that potentially this is safer. I mean, you just said that, Rob, safer than some of these plating or IM nails. So percutaneous technique, you drive the alignment with a computer software, heals predictably. and you can adjust your alignment and torsion and all components of alignment. So, and you can see here all percutaneous holes from the half pins and wires. All right, so that's me and my intro. We're going to pass it over to Dr. Rosbrook. You can go ahead and screen share, and feel free again, guys, to ask questions. And thanks again for being here.
All right. Thank you, Mitch. Can you guys see that okay?
Yeah, looks perfect.
Great. Okay, so first of all, I want to thank you for the opportunity to be part of this group and to be involved in this exercise. This is really wonderful, and I appreciate that. My focus is going to be on a tibial non-union with deformity as a potential application for the ring fixator. And I'm going to take you through sort of a rationale in a couple of cases. So this is a case I found. This is actually my case from like 20 years ago. And this is how the patient presented to me. And so if you look at it, you know, it's a goofy little fixation that was done by somebody else. This was in the old days where they would plate the fibula and then they would put like a medial spanning fixator, a unilateral fixator. But if you look at it, it's actually a pretty difficult case because the malleolar relationship is really, really off. And so what we did is we used the fixator to kind of just gradually pull down the tibia relative to the fibula. So in one shot, we fixed the varus and we used this until healing. And you can see that the distraction actually led to very nice bone formation. Mm-hmm. So when to think of a circular fixator for a tibial non-union? And I think it comes down to if the patient has deformity, simple deformity or especially complex deformity, if it is a stiff non-union, if there's poor soft tissue envelope, a desire for a gradual correction, a desire for a minimal incision approach, and maybe even a concern about infection, right? I mean, if you have a non-union with deformity, you really, and you do an open technique, you have to be prepared to correct it acutely. You have to be prepared to mobilize it, which is actually can be a big job for a hypertrophic non-union. And so when you're dealing with stiff non-unions that have these kinds of issues, poor skin, et cetera, they really become very nice opportunities for a ring fixator. So let me take you through my first case. 46-year-old male, pedestrian struck by a motor vehicle, had an ORAF of the plating and developed a post-op infection. And at the time, the treating team removed his hardware 8 weeks post-op, obviously before fracture healing. Infection was eradicated and they braced the leg, but the deformity progressed and the patient had moderate pain. So he presented to me looking like this: large varus deformity and a mild procurvatum deformity. You're starting to see already that the skin is not great. It's kind of shiny and tight. It's a stiff deformity. Knee motion and ankle motion are fine. It doesn't appear to be any active infection, but you never know. You never know until you get in there. So there's always, there's a history of infection, and so there can be some infection. So you look at the radiographs and you can see there's a large varus deformity with associated leg length discrepancy. And we call this a stiff non-union. Looking at it a little bit more detailed, there's 39 degrees of varus deformity and 11 degrees of procurvatum, anterior translation. So you can see kind of where I'm going with this with a little bit of hexapod planning. So let me stop there for a sec and say, Mitch, what do you think? I mean, is this something that can be done easily and safely with an open technique and an acute correction?
I was going to ask if you or Steve Well, I'm not gonna not answer your question, but what I'm thinking about as you're talking about this hypertrophic non-union as a post-traumatic reconstruction bias versus acute fracture surgeon most of your time. When you say a stiff non-union or hypertrophic, does that, like, how do you, a lot of people want to know, how do you define that? And to answer your question, if I'm doing internal fixation, if you go back one slide, Rob, this is a juicy one for most trauma surgeons because it's diaphyseal. So right away, I think in 2024, a lot of us are thinking IM nail, right? Even medial distractor, and just crank the medial column out, cut the fibula obliquely so it's shortened. But that's a lot of work to do to get that straight. So
But you also have to look at how much shortening there is relative shaft over shaft. So to acutely get that all the way out would be a bear. You'd probably have to resect a little bit of the tibia to get it there, I'm guessing.
well,
Yeah,
you're gonna
and you
be
can also
handsy,
see
right? You're
that
gonna be very handsy with this case, right?
and you can also see that the IM canals don't line up. So, it's not when you talk about a stiff non-union, I mean, sure, if you can go there and you can like in the clinic, it's moving around, that's a different ball game, but this guy's been walking on this thing. So it is stiff. And the takedown process is not nothing. In other words, if you want to take something like this down to do an acute correction, you've got to take it down a certain amount. You've got to open up the canals. You've got to mobilize it. And you have to usually make a big enough incision to accomplish that safely. Hypertrophic non-unions also, they tend to be wide. So like the bone that you're operating on now, all of a sudden, it's not like the normal size. It's like 3 times the size. And all of a sudden you're like really stretching and aggravating the soft tissue. Well, listen, I think the point is made. I mean, listen, there are going to be different approaches, but I think the point is made. Like this is not a simple, safe, acute correction of a deformity with just put in internal fixation. I mean, there may be some people who can do it and do it safely, but let me show you a little bit more on the case, and I think it'll sort of come to life. I like to make a problem list. So at this point, it's a stiff non-union, hypertrophic, history of infection, oblique plane deformity. So not a simple deformity. There's translation, there's procurvatum varus, and there's really poor skin, as you'll see in the next slide. And there's shortening that is not insignificant, 3.2 centimeters of shortening. So my plan for this case was to use a hexapod technique, gradual correction, safe for neurovascular structures, safe for skin, minimal incision technique, and I did a fibula osteotomy. So I actually did this in a very purist kind of way. The only incision I made was the fibula. That's all I did. I didn't touch any.
Whoa, you did not, you
No,
did not, you did not touch you did not drill percutaneously slide an osteotome in there?
nothing. You see the skin?
You swear.
I swear.
Steve, are you a purist? Are you hypertrophic non-union Elizarov style? You're not touching it?
I think that deserves a whole nother discussion, but in this case, I think I'm with Rob.
This is what I did. This is what I did. I mean, this is not a new case. This is not a new case. I will tell you, this case is 20 years old. And this is what I did. And this may have even been my first spatial frame. Maybe not. But this was early on in my career. And this was my fixator. And this is what I did. And I just distracted him. Very purist. I did 38 days of distraction. And this is what we achieved. And at the end of distraction on day number 38, this is what it looked like. And it pulled apart really, really nicely. And you can appreciate that there's some obliquity to this non-union, right? It's an oblique plane non-union. And what I did was, oh no, it froze.
You're frozen.
I froze. All right, let me
Okay,
go
go
stop.
ahead. But there is anyway, while you're doing that, a question. Steve,
There.
if it looks more like a malunion, okay, so and if it looks like a malunion, and or you don't want to say it's a stiff non-union, or you're going to treat practically it as a malunion, why not a single oblique mathematically oriented osteotomy with, let's say, plating?
So there are certainly times when that approach would be very appropriate and it could work well. The limitations on that in a case like this relate to a few things. So one, he's already shown that the soft tissues here are not optimal for a plating. So that is certainly one limitation. The other one is that to restore the length in this case with a plate, again, you would almost certainly have to leave a shortened extremity. If you didn't have a length issue and the soft tissues weren't a problem, then certainly I think that approach is one that you could definitely consider. But at least that's how I would kind of look at the problem.
Okay, and then just because I think, like Rob, do you like the idea of this is not the right way, but one right way type of idea? I mean, you mentioned that, right? This is not the only way to treat this case.
Of course not.
Yeah.
No,
Okay.
of course not. Um, the I did one of the nice features of the hexapod is that you can induce oblique plane compression, right? In sort of classic Ilizarov, you can, pretty much you're mostly doing axial compression, but you see you can program an oblique plane compression by sort of playing with the amount of short and the amount of translation. So that, I did that, which was helpful. And then, so this is what it looked like, at 2.5 months. John Herzenberg used to say that the neat thing about this technique when you're dealing with non-unions is that you open up the non-union and you open a window into the non-union and to bone healing. So, you can start nerding out on this and start looking at what is actually going on in there, right? I did not do anything, didn't inject bone marrow or anything. And I, at some point, it looks like I converted it to rods. I probably was being extra cautious here. But this is kind of the progression, right? The before and then like the frame matching the deformity and then the end distraction. And this is what it looked like on the x-rays. And this is him fully healed. And this is the end result. Again, no touch technique, no open osteotomy. This is pure distraction of a hypertrophic non-union.
Okay.
Yeah.
Okay, go ahead. Finish. Didn't mean
I'm
to
just going
interrupt
to
you.
say
Go ahead.
this, when I first got into this business, 25 years ago, this was fascinating to me. As a trauma guy, the idea that you could pull apart a non-union and make bone and actually distract bone. In other words, induce bone formation with distraction in the setting of a non-union was really, really fascinating to me. I mean, I didn't discover it. We didn't discover it. This is was one of the Ilizarov principles, but it's one of the amazing things.
So here's a question then, Rob, related to that exact thing. So when you're looking at a non-union, we can certainly say that this one was stiff. It's got callus all over, the guy's walking on it and stuff. Apart from ones that are overtly, clearly hypertrophic, how do you decide if it's a good idea in any other, let's say, middle of the road non-union, whether it's a good idea to just distract it or whether you may want to do something more or take a different approach on that?
Well, I like the idea, what you have to do is you gotta cut the tibia, you gotta cut the fibula to truly get a sense of how stiff the actual tibia non-union is. But the ones that are the most appropriate for this technique are ones that are pretty stiff. I mean, you don't want it to be completely healed because that's not going to work. So you want it to have about, 5 degrees of motion. You want to be able to document that you're changing the position, but it's stiff. I mean, listen, this is a 39-degree deformity. So even after doing an acute correction, there's still like 34 degrees of deformity. Acute correction of 34 degrees of deformity in the tibia is not safe. It's not safe. And with a poor soft tissue envelope, I don't think it's safe. So I will say I did this case, 20 years ago, but if I had this case tomorrow, I would do it the same way. And listen, I love using plates and I love using nails for deformity correction. And but that's a big deformity. I don't think you can do that safely, acutely in this particular setting that I've described.
I think one of the other things that sometimes I look at on this is I look at a CT scan of it, and if I don't see any signs of callus trying to form around it, that might push me to thinking it needs a little something more. And if I see some callus around it, that encourages me that if I just pull it apart, it is going to form good bone there, and they usually do.
Yeah. I mean, I think the question comes up, do you make a small incision? Do you drill it? Do you kind of, stimulate it? And I do have a pretty low threshold for doing that. I think that, but I think if it really moves, you probably don't have to do it. But can you do it? I mean, I don't know of any, controlled studies that have really looked at the difference between a completely, no touch technique versus a minimal, incision technique to just add a little bit of add a little bit. But, the biology of this is really pretty amazing. It's not new. There were a bunch of studies that have been published. This was one that reported on a series of 21 of these. This is another that reported on a series of 10. And these are some additional research studies that really mention and talk about hypertrophic non-union distraction. A word about the biology. Basically, the understanding is that hypertrophic non-unions have dense fibrocartilaginous tissue. So, I mean, again, in this history, remember, this guy had a plating and then they took the plate out 8 weeks after the injury. So clearly this thing, failed and became a non-union with deformity because it was missing, the alignment and the stability that it needed. So what's amazing here is that, yes, so the biology is okay. In other words, there's no dead bone, and the distraction actually leads to bone formation, just like compression leads to bone formation. It basically transforms the fibrocartilaginous tissue, and the non-union and that tissue acts like an interzone. The hexapod frame abolishes the shear forces to induce bone growth. You can do a gradual correction of the deformity and the non-union. And as I was saying in this case, it's ideal when the soft tissue is poor, because it would otherwise be very difficult to and perhaps risky to do an open approach and an acute correction.
Okay, we have 10 minutes left for Rob, but a Quinnen question from the audience. You said do something more, Steve. You said do something more in regards to if the non-union will heal and form bone with distraction. What do you mean by that is the question?
Yeah, absolutely. So if something is really truly atrophic, then I may still, if it's short like that, I might consider still distracting it. But I might do one of two other things. If I did distract it, I would maybe at the end plan to either prepare the bone ends and put them together, or add some graft or something to encourage it to heal biologically. Or alternatively, on occasion, I will make an osteotomy at the level that it needs to sort of translate over, and just distract it out and kind of leave that non-united part where it is. So those are like a couple other ways to deal with it. If it looks really atrophic, then sometimes those other methods are something to consider in the protocol.
Okay. Rob, let's get you to your last case.
All right. The next one is a little bit shorter, but just another example. This is a more contemporary case. 35-year-old with a non-union after an osteotomy. So somebody else had done an osteotomy, and he presented to me like this. So the guy has a stiff non-union. It's in varus. There's medial translation of the distal tibia and fibula, and this skin is not great. It's matted down to the bone, as is the skin in that area is vulnerable, and in this particular case, it's really matted down to the bone. So again, I'm thinking to myself, I'm going to use a hexapod for this because it checks a lot of the boxes of what we had just talked about. I did my hexapod planning with my origin corresponding point. I find that Saltzman view to be helpful adjunct for distal tibia ankle types of deformities to get a sense of the alignment of the heel versus the tibia shaft. And so in this particular case, I put a fixator on. Again, you know, if the skin looks okay, in this case, I did make the skin that was not great was the medial skin. So in this case, I percutaneously injected with a bunch of sort of stabs. I injected some bone marrow combined with a little bit of Ignite, which has a little bit of DBM. You know, it's always a question about whether that adds, how much value that adds. But you can see the deformity correction was quite nice. We really got we corrected the deformity, and I corrected the translation. Again, I will, you know, put a real plug in for this concept of oblique plane compression that you can do with a hexapod frame. So you can really abolish the shear forces, and then you can actually compress in a way so that you're not creating more shear. And so this is what it looks like. Frames have gotten a little smaller over the years, a little bit more streamlined. Of course, weight bearing is encouraged throughout the treatment. And now I'm planning for the frame removal. And Mitch, this is something you and I had talked about. You know, sometimes you take fixators off. You know, when to take a fixator off is the magic question. And maybe that's worth a moment or two after, you know, I show you here. But it makes, you know, whenever I take a fixator off, honestly, after I've lengthened the bone or after I've corrected a non-union, there's always a little part of me like, did I leave the turkey in the oven long enough? Right? Because it's like what you don't want is you don't want to refracture. It's not that the bone is not healed. Like I was confident that the bone is healed, but it's like, is this guy going to refracture? You know, how much spot welding is there? You know, and so what I did in this case, and I don't have an exact protocol for this, but I did a percutaneous. This was literally 2 percutaneous screws. So there was no soft tissue disruption here. I intended to keep these in permanently. So you see these are headless compression screws. And I did these percutaneously, not to get it to heal, but to prevent refracture. And then he came to see me. He came to see me last week, actually, just to show me how amazingly well he was doing. And you can see he's kind of back. He's gotten his musculature back, and you can see the remodeling that has occurred. So, you know, I'm going to conclude with this same slide I used at the beginning, which is, you know, when do you think of a circular fixator for a tibial non-union? And so my answer is, if you've got a case where there's deformity, if it's stiff, the biology is pretty good. If the skin is poor, if you would like to do a gradual correction and avoid an acute correction, if you would like to do a minimal incision approach and avoid an open technique that requires more soft tissue dissection, and even if you have a little bit of a concern in the back of your head is like, is there still infection in there? You know, again, the fixator might be your real friend and might help you through these difficult cases.
Thank you.
Again, this is, you know, this is one application, but for me, and as a guy who's not really doing a lot of acute trauma anymore, this in the post-traumatic world, this has been one of my indications that I've really held on to, because I, like everybody else in our community, you know, I've gone to doing much more stuff with acute correction and internal fixation. I love and really have become very passionate and pretty good at, you know, the fixator assisted blocking screw techniques with with intramedullary nails. And those are great. You can really get away. And in a lot of cases I would have done with a fixator 10 years ago, I'm doing now with a fixator assisted blocking screw nailing technique. But this particular indication for me has really, really remained a compelling compelling case for the use of the fixator, circular fixator.
Can you zing back to the first case, Rob, with the frame on? I mean, for people watching, pitfalls. I'm thinking pitfalls when stiff non-unions in terms of frame build. Do you do anything different? I saw you had a ring block on that patient, which is obviously really elegant, just like plating in terms of working length. You or Steve, any pitfalls for treating a stiff non-union in terms of frame building, half pins, wires, distraction rate, latency period? Like, I don't want people yelling at us after if they try it and it didn't work. Like, what would you not want to forget to mention?
It's got to be a strong frame. When you build a frame, think of a frame as being balanced, just like plating, right? It doesn't make a lot of sense to, put 2 screws on one side of a fracture and 8 screws on the other side. You need balance. And it's the same thing with a fixator. You want a balanced frame. You want to have enough fixation, spread out your fixation. So you want it far, near. If you have a smaller segment, then you need more fixation in that segment. And so, you can use ring blocks of 2 rings, or you can use 1 ring with multiple extended points of fixation, but you do need a strong frame. And the frame that we build for just like correction of a stiff non-union with deformity is different than the frame I build for a lengthening in a pediatric patient. I mean, they're different frames because they're trying to accomplish different things. This is a very stiff, strong, far, near frame with at least 4 half pins on one side of the diaphyseal side, and on the other side it's going to have at least 2 or 3 wires and 2 additional half pins. So it's got to have some meat to it to be able to do that.
I
One
think the other
question.
thing- yeah, far, near is definitely key, but also having a big angular spread in your fixation, especially if it's half pins. They really need to come in from different angles. It's just all part of the biomechanics.
Steve, you talking about like in the axial plane, or are you talking about like more steerage pins, like angled?
Axial plane, most importantly. Steerage pins can also be helpful to try to neutralize some of those more oblique plane issues with the fractures. But I think in general, in the axial plane, having a spread of what they're coming from, it helps prevent cantilever in any given plane when they're way off axis. So especially if you're using a half pin construct, I think you really need to make sure that you have that done as well.
All right, Steve, let's get you going.
I have one last
Yeah.
question. Do you
Yeah.
think, because you and I have talked about this internal fixation at the end of a treatment, and we were actually going to put a few cases together. So this was one of those.
We are still.
Do you think, like, what did you think about my last move there of putting those 2 screws in? Did you think that was nice? Did you think it was unnecessary? Like, what did you think of that?
I don't know if it was necessary. I think it was definitely necessary if you wanted to take the frame off earlier. I do like the corridor of the screws you chose and the screw you chose. So I like the intramedullary fibular screw, makes sense. I like it. I like the size of the screw you chose. And on the medial column, I like the fact that it's sort of bicortical. It's grabbing the lateral cortex of the tibia. I think that's very nice. I'm not sure you needed it.
Right.
Not saying you didn't need it, but I'm not sure you needed it.
Right.
My question, Rob, was why you didn't do it sooner. No reverse dynamization?
Oh, you mean leave it while the fixator was on?
Yeah, put it in after 6 weeks.
Well, we're gonna publish that. Let's not discuss that here. This is not a secure line here, guys. I think we should
Yeah.
I think we should
Because then
move
when you do
on.
it heel
We're
quicker,
gonna
and
define that.
you still have your stability after if you put it earlier. So that's why I wonder. But
Yeah, but it's not, yes, but it wasn't great stability. It was one screw. You know what I mean? So I chose that more for sort of preventing refracture. I'm not sure that like that is not a very that might not have been strong enough if I had taken the fixator off 6 weeks earlier.
no, I'm saying like after 6 weeks on, just put the screw across it in a reverse dynamization fashion, and that would encourage it to finish healing a little quicker.
But that's another surgery.
He's a big bite of glad.
That's a third surgery.
That is an extra surgery. You are correct.
And with that, let's move on, Steve. Go ahead. We're losing 2 minutes here. We do have one question, Rob, while Steve's pulling up his slides. Steve, let me know if you need Rob to stop sharing.
Oh, I have to
Yeah, Rob's got to stop.
Yeah, okay. Got
Okay,
it.
quick, because we're cutting into Steve's time because we gotta finish this. Rob, medical, a lot of patients are older, medically unwell, hemoglobin A1C cutoff, etc. So you say, well, I'm not doing an ORIF or an open approach, but does that mean they're okay for a frame? The question is, which medical patients do you not put a frame on? Diabetics,
Yeah, it's a great
dialysis.
question. So it's frames are minimal incision surgery. And so the stress of the surgery is actually less. And that's an important point. I'm an uncontrolled diabetic can be a disaster, but a well-controlled diabetic's okay. I think patients tolerate frames very well. The only patients that are absolute disasters in my experience are diabetics with renal failure or a massively uncontrolled diabetic. But a well-controlled diabetic otherwise does pretty well. And I've even done them on PV, peripheral vascular disease patients, where other people were concerned about doing any open technique, and it worked very well.
Okay, thank you. All right, Steve, sorry to take some time. Go ahead, Steve. We will not talk to you.
No worries. Oh, you're allowed. No worries. So obviously, we looked at some really great cases, and I agree with Rob that those non-unions that we saw, excellent cases for using rings. But I'm going to focus a little bit more on some of the acute trauma cases that are still really, really nice times to have this tool available. And we'll kind of start with the one that I think in some ways is a little more straightforward. So again, getting back to sort of medical problems related and stuff. This lady, 68-year-old lady, she had a 10-year history of pretty bad venous stasis disease and had skin changes from it pretty extensively in both legs. She fell down her stairs, and you can see here that what we have is sort of an extra-articular pylon, and this is the skin that we have here. So taking a look at that between the blisters, the way it's plastered down, and the obvious chronic situation, I think I don't think anybody's very excited about making incisions on this leg. And is a nail possible? Well, I'm never one to say something's impossible, but that's a pretty small segment to get significant locking screws in. And so I think that that's a bit of a challenge in this case, although perhaps it could be considered, even though it's a bit of a challenge. So we took a look there and said, well, what are our other alternatives? And for a fixator, this is one that really could allow for many kind of ring fixators, including traditional ones as well as the hexapods that we saw earlier, and both could be very easily applied to get this properly aligned and acutely, or at least pretty rapidly reduced appropriately. We take a look here, you just sort of confirm that it is extra articular, even though it's very low in the front, and it also has this little crack in the back. So it's pretty far down toward the joint surface. For that reason, when we take a look at the overall picture, what we ended up doing here is we used some wires in the distal tibia, didn't have a great initial corridor to place a half pin on the get-go. So we extended our fixation across the ankle with a foot plate. And I think that that's one of the things here, then we'll see that with pylons in general, that the ability to extend your fixation construct onto the foot for periods of time during the treatment gives you a huge advantage when the fixation in that distal block at the articular surface is limited. We might have been able to get away with just having a thinner half pin right then and there, but instead we basically used that as our fixation, and within a relatively short time, we had her healed. This was about 4 months later. And you can see that as the fixator was on, her skin recovered. All the percutaneous technique, you see we've spread our fixation far and wide. We have angles to it, and we had the wires spread across to get our adequate fixation. So, I think that this is one example that sort of gets back to what Mitch started with, which is when we have really bad soft tissues, sometimes the ability to do this all percutaneous without touching the fracture directly provides us a real opportunity.
You know what? You know what's not? I guess it's not ironic, but like it's very AO to do this case. If you go back a slide, I mean, the cases that you guys have shown so far are so amazing. Like, look at this case. Like, you know what I mean? What a safe way to
Yeah.
get there, Steve.
I want to add a sort of a philosophical idea. If there's anybody out there in this audience who really is interested, everybody who's listening to this fireside chat presumably has interest and has some expertise, or at least desire to obtain more expertise in using a fixator. Steve, I would say, like if you don't use a ring fixator to take care of this fracture, then you'll never use a ring fixator. In other words, like it's like why are you going to work? Why would anybody work so hard to figure out, like, to put a nail in this fracture is just
then they present at the webinar for extreme nailing.
It doesn't make any sense.
Not to knock
so
it.
if you have this is my claim, and if there's anybody out there who's interested in these techniques, it's like this is the technique. This checks every single box. It's like you don't have to be apologetic for using a ring fixator. And if you're not going to use it on a case like this, then you might as well never use it.
It's true.
Yeah,
it's a very difficult problem.
I felt the same way. So congrats, Steve, on this case.
Good deal. So let's look now at a different one. And I think that
Steve, one question. I said I wouldn't interrupt you. The ring block for the foot, are you building that ring block first and we potentially will talk about it later with Hudson's technique, but are you putting this distal tibia ring first and then adding a foot ring, or are you building that ring block together? Just quickly.
Very, very good question. For this kind of a case, I don't think it matters a lot. I think that you've got an articular block that you can work with to get some fixation in for that distal ring, and you're really looking for extra fixation in the foot. The next case we're going to look at is a very different story, and you have to have that foot ring on first. But in this one, I think you could go either way. So good thing to point out, Mitch. Thank you. All right. So we'll move on to a different one here. So 42-year-old motorcyclist hit by a car. He had a really bad femur, and he's got this open pylon. So it's open. We don't know how much bone is missing. Initially, it doesn't look like a lot in that picture, but the picture's deceiving. And once he's pulled out to length, you see here we're missing some bone in the area. He's had some PMMA beads in there. And we see that there's some fracture lines there, but it's not until you look at the CT that you really start to appreciate just how bad the situation is. The comminution here is extensive. It's sort of ground glass. There is a piece or two of cortex jammed in there, which if you look at that, I feel is very important to notice, because ligamentotaxis will help reduce things, but not if there's a piece of cortex jammed into there. So that really should have come out already, and it will come out before it's all said and done. But the real key is this. So we did decide to use a fixator on this case. And what I want to point out is several things. What we did first here is we applied that foot ring as you discussed, and we got traction on there to see ligamentotaxis. Before we did that, we had done the open approach to be able to get in, to get those cortical pieces out. And my goal was to try to put together as much of the joint as I could with some mini fragment screws. But I only actually was able to get some purchase on a single screw. The rest was so comminuted it couldn't even hold a 2/0 screw anywhere. But when you look at it with the pure ligamentotaxis that we get with the fixator, a stable block above, 4 pins, well, it's 3 plus a ring cluster because we're going to lengthen him. And down below, we really just have a pretty robust foot fixation block. And in this initial go, I don't even use any pins or wires in that distal articular block for 2 reasons. One, because first of all, there's not very much for me to hold on to. And 2, because there are some devitalized pieces in there. But what we have the advantage to do with a fixator in this kind of really ugly case is allow the joint to heal. And the joint typically does heal within 6 to 8 weeks. In this case, we did an osteotomy above, and the osteotomy allowed us to lengthen the top so we didn't lose time while that articular area is gelling together to actually form a bone. Once we're able to get it down to the site where we need it, now we have a shaft that we can reduce against that will actually be able to heal and support the articular block when we put the wires in to compress it together. Whereas before, that would have been a bunch of wires in a bunch of sand, you know? So this is a way that we're 2 months out, so we have a successfully healed joint surface. And before, if you looked at it, that joint surface looked like a good joint surface, but it wasn't really angled, right? It was just floating there healing. We've given it the time to heal. We've brought the bone down to it so that now we can reduce it like a simpler pylon would be reduced. And we go on to actually get a very nice alignment and a successfully healed bone. The whole process in this one, I kept it on for about 8 months. I probably could have taken it off a month or so earlier, but sort of back to that question of, is it baked enough? And this is him with it all out. So this is about the most comminuted distal tibia pylon that you could ever find, and it is missing bone as well. And you can see that with a fixator, we get the advantage of being able to use that foot plate to span the stability across so that we can get the joint to heal, even when it's in a place that plate and screws wouldn't hold it. Even the wires from the fixator would really struggle to hold anything there. But given the bit of time that we gave it and the fact that we had ligamentotaxis and some little mini stuff to hold it, we were able to get a pretty damn good result when you look at the anatomy. So I think that this is another really, if you really want to salvage difficult pylons, there is nothing as powerful as a fixator to do it. And I actually like an old school Alizaroff better for this kind of case than I would like a hexapod, because the rings are more visible to see through, and it's easier for me to do the reduction with the ring spread up high so I have space to work while I'm getting the joint right, and then just bring it down straight on where it needs to go. It's not a bad idea to necessarily use a hexapod when you're ready to dock it, but it's actually an easier case to do it the old school way when you've got this kind of a setup here, at least in my hands. I mean, I don't know your thoughts.
Rob has his hands up. Rob has his hand up. I'll
Yeah.
let him go first.
Go for it.
Steve, that's amazing. That's you're a master. That's amazing. I have a question for you. First of all, I really like the idea, the way that you waited on putting the wires in the distal segment. That was very clever. But here's my question. Your end result looks really awesome, and the joint looks beautiful, and hopefully the patient does well. How much of the like the positive result you're going to get on this case, how much of it comes from distracting the ankle in the Pylon? In other words, separate from the fact, I'm asking a very specific question. Separate
Yes,
from
and it's a very important question too.
separate from the fact that you used it as a reduction tool, separate from the fact that you used it to increase your fixation. I'm talking about separate from those issues, just the fact that you actually distracted the ankle for a period of time in a Pylon fracture. How much does that contribute to the positive result you're going to get from the ankle? And then the corollary of that question is, should we be thinking about doing spanning ankle frames in combination with Pylons that are fixed traditionally with plates and screws?
Fantastic questions across the board. So I'll start with the first thing. Yeah, you really brought up something that's a critically important point. When you dock this and you push together the shaft and the joint surface, you must distract across the ankle at the same time, or you're going to crush the joint between it. But that also does give you the advantage of an ankle distraction, which we know is beneficial for the underlying cartilage. So agreed, I think that it actually is a very significant factor, but it is incumbent upon the practitioner to make sure that you are distracting the ankle while you're compressing at the docking site. I think that that concept, which I didn't mention, but is very important, is great. I also think that your point about fixing it with a more traditional plate and screws and protecting that badly damaged joint surface with a distraction at the same time is totally reasonable. You could absolutely go in and if you're able to do a good fixation, but that anterior crush or that central crush can settle around screws in a locking plate. So that is a time when you might want to just throw on a neutralization frame, easy to put on top of it, to protect that highly comminuted surface and give yourself the opportunity to do a distraction, which will probably benefit this very damaged joint. So absolutely very on point, of course.
Steve, let me talk also. I want to congratulate you as well. And I have to congratulate both you and Rob because you guys are like friggin', I don't know what race car you guys like. And you're so humble and relatable that you're showing really, really awesome cases for the audience. So congratulations on these cases because I know you have an armamentarium of insanity. So thank you for showing relatable cases, but still very elegant stuff. Can you go back? So I agree with Rob, and I really learned a lot from you tonight about staging the joint wires, which I'm always like so addicted to, throwing in as many, 2 or 3 wires across that joint. How do you, so you have your Elizarov type frame, and you go back, so is that a dummy ring? So my question is, how do you deploy? I guess you built in a dummy ring, and then that ring came down and got those wires. That was my question.
The dummy ring that you see, which you can see the 2 bolts front and back there. When we were working on the joint to get those cortical pieces and stuff out, that dummy ring was as high up as it could go, near where that pin is, so we have a lot of space to work. And we just brought it down to where we're going to need it for stability for now. And in the future, we're going to line it up with where the joint surface needs to be so we can throw our wires in. So it's just sitting there waiting for us. Cool.
Nice.
So
and again, back to Rob's point, like, would you, like 2024, are you using an Elizarov construct? Because, different there's people from all around the world online. You're still
for this kind of a pylon, for a crushed pylon, the advantage of a hexapod is not typically worth it. That the traditional frame like this is easier to apply to get the straight traction that you need, to see what your reduction work is going to do and to work around. So in general, we're gonna use a more traditional frame like this. In this case, you'll see that it looks like there are 4 rods down it. So we probably had initially we had two in the back the whole way top to bottom, and we would have spanned with just those two initially and brought the other two down after we did whatever open work we had to do. So that's how you get your access to the front and use the foot to distract when you need to access the joint to get things where they need to be. But then you add those down to get the stability to be able to make the frame later.
Rob has another question,
Yeah,
and
I
then
just
we
want
got
to
to
make a
get you
comment.
done here, Steve.
You
Yeah.
know, just for the audience, the ability to use, this is a very old school bone transport frame. And you made it look easy, but this is not so simple because it's very unforgiving. Like this has to be lined up perfectly, because if you're not lined up perfectly and you transport, you're going to end up like this, and it's really hard to fix that. So, one of the advantages of, just as a general point of in bone transport, one of the advantages in general about using hexapod frames is that as you're transporting, if you're starting to do this, you can reprogram it and then bring it back. So it's just it's just a comment. Steve didn't need it here because he's a master. He lined it up perfectly and it docked perfectly. But if this thing is off, it's not easy to make it better.
True. And that'll actually segue into the other little slides I had, which are a few, and then into some of the articles that we had to reference. So I'll speed back to where I was. So this is kind of one of the things I thought, at least for pylons, was worth looking at. Is like when you look at a pylon and you're going to consider if a fixator is something you might want to use, and which kind of construct you might want to use. The old school A-type, B-type, C-type concept is actually very helpful. And in my mind, an A-type, like that first one I showed, it's extra articular. It may be very low or whatever, but it's forgiving because we can put a small fixation block either into there or onto the foot. And easily we can use a hexapod fixator to dial it all in and around and everything you want. So that isn't sort of an ideal case when you're going to use a ring to use a hexapod for. And that's pretty much what I would do for any of these sort of A types or simpler Cs that you can make in A. Now, B types, partial articular ones, in my mind, they are the worst fractures to use a ring for. And the reason is because the intact piece and the non-intact piece, the wires have a little bit of play in them. And so the articular reduction has to be maintained with screws or plates and screws. It has to have internal fixation to work. It has to. The rings alone are not really very good for that. So if you have a place where you really can't use a nail or a plate and the soft tissues are terrible, you can add a fixator just as a pure neutralization construct. You're going to put it on, you're going to put pins and wires, you're not moving anything, you're just keeping it neutral to protect it while it heals. So that's the way that you would use it, and it can be any kind of construct, but it's not particularly mobile. It's just a static fixator. Then we get to RC types, and this is really where it gets more interesting. So simple articular fractures, we can use either cannulated or mini fragment screws. Usually when I do that, I put them very low so that they're near the joint. So I have room above that that's not in the joint capsule for wires and stuff. And it turns it into an A type, and then we can follow the rules for the A type. You can either use your Alizaroff wires if you use Alizaroff, or you can use the wires and use the hexapod to reduce it, or some combination thereof. But for the C types, getting back to it, the most important aspects, get rid of any impacted cortical pieces, or if there are impacted joint pieces, you have to physically push them back down into space because ligamentotaxis will struggle with those two things. You're going to apply the foot frame in a way that you can distract it from the above ring block so that you can get distraction in ligamentotaxis. Once you've done that, if you're ready for the wires, you can basically put them in and just vary how far they are off the ring. And that's how you're going to reduce using the Elizarov method, the old school method. You're going to use wires to move the blocks the way you want to go. And if it is a multi-fragmentary one, as we said, we can we can go to the hexapod. But if it is really one of these highly comminuted impacted segments, we're probably going to use wires for the fixation to compress it. And I like to wait a little bit to let the devitalized fragments and everything gel together and get a little blood supply back, which to me is usually about 6 weeks. So that's sort of my view of an ABC and the constructs you might want to consider for those different kind of fractures when you're looking at, do I want to use a ring? Anything I miss, Rob and
Yeah,
Mitch? Or
yeah, I have a question though, but you know, now I'm confused, Steve.
Mhm.
You have to clarify something because you know you're talking now like an Ilizarov surgeon. You're talking like a guy who uses a fixator for all his Pylons. And but
true,
are
but
you
it's not
that
the
guy?
case. Not
Are
the
you
case.
that guy? And if you're not that guy in the year 2024, how, you know, it used to be easy. You were either, you were either a this or a that, but now we're a little bit of everything. So how do you decide on a Pylon fracture to use these incredible Ilizarov techniques that could be used for all Pylons, right? They could
Sure.
be used for all Pylons versus more traditional American contemporary techniques, which are like, staged and open plating techniques.
I mean, I think that the convenience of having everything be internal is very large. And, the great majority of pylons that I treat with plates, or if I can get away with a nail, I love nails. So in a lot of those cases, I will use those methods, and it's the majority. So the couple things that drive me to use these methods really, it gets back to soft tissue status, probably is maybe the biggest one, or extreme comminution in the anterior and central plateau or plafond. Those things are hard to maintain in the long term with plates and screws. Even if you do your best work, they're still hard. So a fixator, especially if there's bone loss associated in those circumstances, is nice. I will say that doing a more traditional method and then putting a fixator over it is a very reasonable option to protect in those scenarios. But the difference is if I am gonna have the frame on anyway, I'm not really sure that I would prefer to do the plating early. I will also throw in another curveball that I have done an Elizarov for a couple months to get everything healing early, and the way we would do it kind of without putting the wires distal, and then I put a plate on when things were a lot more stable as well. So that's a third option. But regardless, those are the times when I would think of it, but most closed fractures, especially here, would get traditional plates and screws in my hand.
All right. Steve, are you done your slides?
I am done, my friend.
Well, wow. To the minute, we are on time. Okay, so traditionally we have a journal club, but to have a journal club on ring fixators is awkward and would take, 6 or 8 months. So we're gonna just show something I think that'd be practical for all of you who might be interested in ring fixation. So I'm gonna show you here. You guys can see my finder here. So we're looking at Jim Hudson's articles here. I'm just going to reshare my screen to, hold on, guys. You see that okay, Steve?
I see it well.
Okay, so maybe Steve, I'll have you introduce this article and maybe just 30 seconds on Jim Hudson.
Yeah, so Jim Hudson, well, actually, I had the benefit. He was my senior partner for the first 10 years of my career, and he's the most sort of experienced trauma Elizarov surgeon in North America before he retired. And he also had a penchant for making really, really helpful pictures. And so he had an entire edition of Techniques in Orthopedics, which had all of these different articles that you see here that lay out in detail, step by step, of how you would actually do each of these procedures for these different indications. And it's one of the nicest sort of Elizaroff cookbooks that I think you could ever find. And I think a lot of people have used it as their reference when they learn to do some of these techniques. So Mitch, if you want, why don't you pull up the distal tibia one? I think that one's like a good example just to show, how it's laid out and how it can really be helpful for somebody who's looking to do one of these cases, to just sort of take you through like what would I actually do step by step? Because that's what it's intended as. It's intended as a play by play. How am I going to do this? And you'll see that he has the different figures that go into it. If we sort of scroll down a little, a spanning frame, some of the things to look out for. You got the stable base concept. If you go down one, Mitch. So the stable base, we talked about spreading those half pins. And then you'll see that you've added on that additional fixation ring. It shows how to reduce, which we didn't talk about much, but if you're using traditional techniques, an arch wire will move the bone one way or the other. If you're going to if you're going to rotate, you're just going to move the position of the fixation points around. And it just lays out all of that step by step. What steps you need to do to set up the ring, what steps you need to do to reduce it to get to a successful result, both in the text and the pictures. So I would really encourage somebody who wants to really look at the traditional methods and understand them better. And certainly if you're thinking to go and tackle a case, these are just really priceless to look through, to just give you really probably the best cookbook there is to try and do this stuff.
Yeah, I mean, we obviously don't have time to go through all of them, but walking through at least one of them with your cases and then just referring it to now is helpful. And then I'll put back again this this is the actual entire volume, right? This entire technique and orthopedic journal was him, right? He has 12
correct.
plus 2 appendices.
The
So
whole edition was all it was all him.
yeah, I'm a little annoyed that I was unaware of this till today. So again, just some of the advantages for doing these AO sessions. So thank you for that. So in closing here, one question regarding the highly comminuted Pylon fracture plus or minus bone loss, would there be a case where you feel a frame would not be the best option and would it choose acute fusion for Pylons?
I mean, I think there are certain patients that are going to be extraordinarily difficult to manage with follow-up, and in the long term that, yeah, it may be better just to do a one-step sort of solution because they're simply not somebody who's going to be able to do the follow-up post-op care that you need.
All right, and can dynamization or what do you feel? There's a question about dynamization, which is always a big question. What are your gut, Rob? What's your thought about dynamization, and like what does that mean for you? I mean, we know what it means, but what do you use it?
It's really confusing because, what it used to mean was that as you were getting closer to the healing, you would make your construct less stable and that it would sort of make the bone work harder, which made a lot of sense and I think was a core principle for a long time. There has this relatively new concept of reverse dynamization is sort of the opposite of that, the idea that, and I think it plays into, it's a little bit the opposite of that. Basically, in the beginning, your construct, especially in an acute fracture situation, might actually have a little bit more play and a little bit more instability, relative instability, and you might create more callus. And then as time goes on, you actually make your construct stiffer and stiffer. I would say that for me, I don't really do much of that. I kind of try to make my frame stable, and it's, over time it becomes, in the beginning it's mostly the frameworking, then it becomes load sharing over time, and then little by little, just the dynamization comes from the patient walking more, putting more effort onto it, and it just becoming the bone doing more of the work. But I haven't found it to be a huge benefit. It's very hard to dynamize a hexapod frame optimally, because of the way the struts work. Much easier to dynamize an Ilizarov type of frame. But I think it's something you can use in your armamentarium.
Yeah, and it's interesting because I kind of think of the origin of dynamization, Elizarov, it was a threaded rod construct, and they basically would back it off a couple millimeters, let them walk around for a little bit, and they'd tighten it back up. And it was almost more of a controlled shortening than it was like just making the frame looser in a global sense. And so I kind of think, hexapods made it a little confusing what it even meant to destabilize it or have it be useful. Yeah, and I think these days,
Yeah, and even that word you said, destabilize, is not, is again a pitfall for people, because
yeah,
that's obviously a big danger, destabilizing any fracture or osteotomy.
I do ascribe to the reverse dynamization principle, though. I do think it helps, and I think
Reverse dynamization, so making it more stable.
yeah, so initially
Yeah.
it's going to be more flexible fixation. And then once it gets to the point where the bone needs to bridge that gap, once you've got your callus and it needs to bridge, giving it extra stability it definitely can speed up the bridging, in my opinion. I mean, that's what I do ascribe to that.
Okay, another question. So Rob and
So Steve, how do you do that practically? So you have a hexapod frame on, and you get it, it was a fracture, you used it, you got it perfectly aligned. It's it's 6 weeks out. How do you make it more stable? What do you do?
So there are things you can do to play with the frame. You can add threaded rods, which will make some difference in this and that. But like at the end of the day, the thing that really makes a difference is just put two screws across it. And
Adding internal fixation. That was what you.
so you do got to go back to the OR to do it, but like a perk screw or two, it gets those things to heal a whole lot quicker. But it is extra OR trip.
what about, so Rob and Steve, assuming you're dealing with a Pylon fracture with bone loss, acutely or semi-acutely, how aggressive, or like just shed some light on when you do the bone transport, like how do you do that? How do you incorporate that? That was a question.
Well, I mean, if there's real bone defect, you have to make a decision on what you're going to do. You can either use sort of a mascale type of approach where you fill it and then come back and bone graft it. Not going to be as effective in the distal tibia as it would be, let's say, in the femur. Or you're going to have to do some shortening across the defect, which is essentially bone transport. You either shorten, you have to shorten it. So you have to kind of decide that kind of stuff pretty early on, depending on the viability. You kind of have to decide that. You also don't want to waste a lot of time. So if you have a fracture in the distal tibia and you really are not confident that a mascale type of approach is going to work, or that you just don't feel like it's a good thing, in terms of opening it up and bone grafting it, the sooner you start the bone transport, the less time you're wasting. So I think making good decisions in a timely fashion is really important.
Yeah, especially Rob, you're seeing a lot of referrals from very good trauma surgeons. And Steve, back to your case, 8.5 months for Pylon ORIF, or, you know, somewhat internal fixation, but getting the Pylon to heal plus a bone defect in 8.5 months, Rob, like that's in terms of the efficiency of care for that patient. I mean, you've seen patients with a problem for 4 years, they come to see you after, right?
Exactly, exactly. And
Yeah.
then patients get fatigued, you know, they get fatigued. And I mean, I've seen patients who have come in 6 months after a Pylon with a spanning frame and their foot in an equinus position. And it's like, man, what was the plan?
Yeah. So people look at your case, Steve, which I don't think they did, but they're like 8.5 months. That's a long time. Actually, for that episode of care, that's an aggressive, efficient way to take care of that patient.
Yeah. And I agree with Rob 100%. I mean, if you've decided you're going to transport, just get it going. Just start making bone.
Yeah. You know, a lot of what we deal with in the recon world is, you know, patients get fatigued. They've had 16 surgeries. You know, they come see you and it's like, well, you know, let's talk about salvage versus amputation. And sometimes, you know, when I present it to them and I talk about a plan that's going to take another year, they say, I can't do it. I can't do it, doc. I don't have anything left. And so sometimes they'll decide on an amputation rather than a salvage because they're simply exhausted because they've been already fighting this fight for 2 years or 3 years. And it's like they've got nothing left. So I think, you know, the idea of getting things done in a timely fashion and not wasting time is important.
Steve, hybrid fixation, specifically trauma frames up in the diaphysis with rings in the articular block for both plateaus and Pylons. Your thoughts? It was a question.
In some ways, so I will do hybrid fixators for a lot of my spanning fixation across pylons initially. I'll just use a foot plate with a couple wires in the foot, and I'll put half pins above, and I'll just connect those and span it like my Delta frame, and that works great. But as a definitive method of fixation, the mechanics of a hybrid is really inferior to the ring. And so if you're gonna go with X-Fix,
Go big or go home.
go big or go home. Yeah.
Okay. Guys, I want to just I want to say I appreciate both of you taking time off work and family time to be here, dedicated to the learners and AO. So thank you, and both of you are considered mentors. So I appreciate our relationship. I'll say that in public. So thank you very much.
Well, thank you for being our valiant leader.
Any final words? We'll give the final word to Rob. Rob, you get the final word for the fireside.
Well, I think, first of all, Mitch, I want to say I'm very proud of you, and I'm
Thank
proud.
you.
I'm proud that you did a fellowship with me, and that you call me a mentor, because you've done some great stuff. And I think, you know, there aren't too many people who have really bridged the gap between the trauma world and the Ilizarov reconstruction world like you and Steve. So I am proud to be on this panel with the two of you.
With that said, guys, good night or good morning, wherever you are. And thanks again for tuning in. See you guys.